Femoroacetabular impingement, basically two types, cam or pincer impingement. Cam is a femoral impingement and pincer is acetabular impingement. In cam impingement, there is abnormal head-neck ratio, reduced or absent offset, predisposing factor femoral retroversion, asymmetrical femoral head, Perthes, AVN, SUFI, and femoral head or neck fractures. Pincer impingement is the one which is acetabular based, anterior-superior acetabular rim overhang is noted. Predisposing factors are protrusive or retroverse acetabulum or os acetabuli. Complicated repetitive macrotrauma can cause labral tear, and osteoarthritis are some things to be considered. An X-ray, a pistol grip deformity is noted, or a crossover sign indicating retroversion. Alpha angle is important, line from the center of the femoral head to the middle of the femoral neck and a line through the point where contour of the femoral head neck junction exceeds radius of the femoral head. This angle is measured if more than 40-55, indicated of cam impingement. False profile view taken with the patient standing, true lateral view of acetabulum to assess the anterior over coverage. 3D reconstruction can be advised. Regarding the principle of surgery, open or arthroscopic, mini Smith-Peterson approach to visualize without dislocating. Acetabular treatment involves taking down of the rectus femoris head, non-spherical section of the femoral head, and prominent sections of anterior femoral neck or rim are resected with an arthroscopic burr. Complications: femoral neck fracture minimized by limited osteochondroplasty to less than 30% of femoral neck diameter. Gans et al. Proposed that early surgical intervention for treatment of FAI, beside providing relief of symptoms, may decelerate progression of degenerative processes.